Myself, Rajat Kumar. I'm heading the division. I'll just 5 minutes of your time to just take forward overall overview of Alembic Corporate. The vision and mission of Alembic is to become a knowledge-driven global pharmaceutical company with the highest level of operational excellence in all the spheres. We have the mission to provide access to the best healthcare products at affordable prices to everyone present anywhere in the world. We have a lot of credits, achievements. We are the first penicillin plant which was established in 1961, which is inaugurated by Lal Bahadur Shastri. We have the largest manufacturers of vitamin B12 in 1967, and we are the erythromycin manufacturers for the first time in India, and biggest producers of synthetic organic API. We have the acquisition of non-oncology business from Dabur Pharmaceuticals in the year 2007. We have ANDA's total file of 38, thereby we got the approval of 415. And we have the first 100 crore brand, which is Azithral, as all of you know. And Alembic is known for the macrolides and cough preparations. Our business, we are there present in API business, we are there in international generics, we are there in the branded formulations. Our global footprints, if you look into it, we are present in global presence in almost around 41 countries. We have the representatives officers in 7 countries, namely Russia, we are in Ukraine, Nigeria, etc. And we are the third-party distribution setups almost around 23 countries and 42 brands available across different parts of countries. Indian business, we are very much there in almost around 17 strategic business. We have very strong in antibiotic, antimicrobial, and antibacterial. We are there in cough, cold, and antihistamines. Gastroenterology, we have a different division. Cardiology, cardio and diabetology, ortho, rheumatology, geriatric, ophthalmology, critical care, dermatology. As well, we are also very much present in veterinary and poultry. All of you know our flagship products. Azithral, we have Levata, etc. We have infrastructure, state-of-art research development centers. We have our office at Baroda as well in Mumbai. We have the Bharti plants. We have Panlev unit, which is the largest fermentation capacity in India and the state-of-the-art research center. We have almost global accreditation and certificates with FDA, MHRA, MCC, FDCA, as well as Australia Government Department of Health. Our chairman, as you all know, is Mr. Chirayu Amin. His message is very clear. Our transformational efforts have only started yielding results. The best is yet to come. Taking forward with this, I welcome each one of you for the Pedia export opinion. Before taking forward Pedia export opinion, I just want to take forward some glimpses of the program, what we have done. In 1907, the company was established. At that time, we are very closely working with pediatric segment. We have actually started this program PEO in the year 2012. Our themes which was followed in 2012 with daily dilemmas. From there we have moved in 2013 with emergencies. Basically this is our objective to provide a platform for practicing pediatricians to discuss on the various day-to-day clinical dilemmas with faculties of pediatric expertise. If you look into the expertise, of course, we are associated with almost 16 to 18 subspecialty in pediatrics. Hematologist, Dr. Anubhav Sachdeva, who is instrumental, who is behind the entire PEO program. When we started, it is basically the brainchild of Dr. Anubhav Sachdeva. We have different specialty which is covered with endocrinology with Dr. IPS Kochar, nephrology with Dr. Kumut Mehta, Dr. Logeshwar with hematology, Dr. Nishant Wadve with gastroenterology, Dr. Rajat Bhattacharya, Dr. Sujata Swaini with rheumatology, Dr. S.K. Chowdhury urology, Dr. Rajiv Kulakshetra with surgeon, Dr. Dhiren Gupta intensivist, Dr. Muthumurugan dentistry, Dr. Kishore Fatke with nephrology, Dr. Maya Vedamurthy, dermatology, Dr. Vasant Kumar, pulmonology, and Ashok Johri with orthopedic. These are all the subspecialty we are actually almost covered, and for the last 3 years we are doing the PU. These are some glimpses of our program, what we have conducted in last 2 years. Today we are here for the West PO program, Pedia Expert Opinion. Normally we used to usually do independently. This time we actually approached Dr. Uday Pai, and doctor has actually supported us to take forward this program, having tie-up with IAP. At this juncture, I actually thank Dr. Uday Pai for giving us an opportunity to have a tie-up with IAP. The benefits of this program, by tying up with IAP, we have definitely got a lot of benefits. All the audience who are present here, they will be getting 1 credit points through this program. With this, I welcome Dr. Uday Pai to take forward this program. Sir, I welcome to the dais. Dr. Sharwari, kindly welcome Dr. Uday Pai. Few words about Dr. Uday Pai here. Doctor is a consultant pediatrician of almost 25 years. Doctor is neonatologist of almost 25 years with principal investigator IS-AAC since 1996. Doctor is having his credits on publications in Indian and international journals, editor of newsletter in Mumbai, contribution on epidemiology of asthma and allergy in children for PCNA 1998, 1,000 plus citations on articles in his credits. Doctor is the president, Mumbai IAP 2014, and right now Doctor is organizing chairman, Pedicon for 2014. EB member, Mumbai IAP 2012, joint secretary, MBA IAP 2011, vice president, IMA Chembu 2001, 100 plus CMEs, RTC, keypads, etc. in his credits. Once again, sir, I welcome and I thank you very much on behalf of Alembic. I request Dr. Uday Pai to take forward this program to introduce our chairperson, moderator for the program. Sir, please.
At the onset, a warm good afternoon to everybody, because yes, the October heat has already come in, and I think this is the first program from IIP Mumbai which is going to be an afternoon program. But the advantage of the afternoon program is, yes, this time we are web linked with almost 16 to 18 centers across, and we have, if we actually account for yesterday night's figure, more than 500 registrations for this program. So that itself shows the popularity of this particular pediatric expert opinion. And of course, the popularity of the program is not only the pediatric expert opinion, it's also the varied range of subjects that we cover. And of course, I'm very happy that, of course, this is the baby of Dr. Anupam Sachdeva and Dr. Lokeshwar for a long period of time. And for the first time, I think this year, we have included a dentistry subject, which probably, we as pediatricians probably try to understand. Do we actually look at the baby's teeth very well? Do they require attention? Do they think that we need to do anything? So I think these are things which probably will give us practical tips of what we don't do in a day-to-day activity. And thanking Alembic, because Alembic has been at the forefront of this activity for the last 4 or 5 years, and rightly we have multi-speciality, multi-specialists who are going to share their experience as well as a lot of insight to what practical tips we can take home from these sessions. So we also welcome all the web link sites, and we also hope that it becomes a very interactive session, and we would like to take this program with questions from all the audience and all the participating web centers. The chairperson of this particular program does not require introduction. He is a teacher par excellence and is a senior consultant and head with the pediatric hematology oncology as well as bone transplantation center for child health at the Sri Gangaram Hospital at New Delhi. He is a recipient of many renowned awards. He is a distinguished DNB teacher of excellence award for 2014. The prestigious BC Roy Award for the development of medical specialties in 2009. The Dr. K.C. Mahajan Award for the best academician in the year 2006. And of course, many more things that he has achieved. And I think students all over India know him for being a good teacher in pediatric and hematology and oncology. Of course, I think both of us probably share one major thing that we are doing this year. I am organizing the Pedicon in Bombay, and he is the organizing secretary for the Pedicon 2015 in Delhi. Welcome, sir. Please take over the sessions. As a part of decorum, and since we are connected by web, it would be a kind request to put your mobiles on silent because it might interfere with the web link. And of course, all of you must have collected the keypads right at the beginning because there are a lot of questions which are going to be interactive in nature and which will require your answering. So I hope all of you have. If you don't, please raise your hand and the keypads will be provided to you. Thank you very much. Over to you, Dr. Sachdeva.
Thank you, Dr. Uday and all the friends. And all the friends from Mumbai. You know, it's a pleasure being in Mumbai, and I must say, at least in this week, I'm more in Mumbai than in Delhi. I mean, it's my third trip in the last 8-10 days, and it's always a pleasure being here. I have great friends here amongst the Mumbaikars. As has been said, that our effort now is that we should bring the super specialists close to the general pediatricians, so that, and also it was an effort that we should bring in out-of-box super specialists very close to the pediatricians. And what are the out-of-box super specialists? This time we have a person who's going to talk on sleep apnea, another person who's going to talk on pediatric dentistry, and I mind you, Dr. Muthu, I was with him in Nepal, at Kathmandu. His talk on pediatric dentistry was highly appreciated. I am not going to talk about all the super specialists because they are well known to you, and they are sort of leaders, and they are the mentors for almost all the super specialities in the country. Friends, I think I will not waste any more time and quickly move on to the program of the day. The first speaker is Dr. Kumud Mehta and Dr. Priya Pez. They are going to talk on pediatric nephrology, and the talk is on approach to hematuria. And I would welcome them on the stage, please, ma'am. And Dr. Priya, please come on to the stage. Ma'am. Some small, you know, for the speakers, ma'am, please. For the speakers, it's important that they should stick to the timing, because with the webcast, we need to have at the end some time to talk to the people who are, or address the questions which have come from the audience from the various centers across the West. I think I'll hand over the mic now to Priya. You'll start off the thing?
I think Dr. Kumud Mehta was going to give a brief
Okay,
introduction.
fine.
Does it go? Yeah. Friends, the topic we are going to cover, Priya and I, is approach to a case of hematuria. I'm sure as a pediatrician you have come, the patients bringing the child's urine, the red color urine, and I don't want to spend more time in it. Red urine doesn't mean hematuria always. Now we have two very important tests which can be done within a matter of maybe 15 minutes to find out whether there is hematuria or not. One thing is a dipstick. If the blood is there, dipstick has made the life easy for nephrologists and pediatricians alike. If you have a microscope, you put the fresh sample of urine and find out if there are more than, some people believe 3 red blood cells per high power field, others believe 5 red blood cells high power field. So your diagnosis of hematuria is made. Now the question is, where are these RBCs coming from? They can start coming from glomerulus right up to the urethra. So there is a big dilemma. How many patients should be investigated? How many patients need not be investigated? If you look at the school children, 1 to 2% of them will have hematuria, microscopic and not of much consequence. You do not want to investigate each and every patient. But what's important, you may have to consider glomerular versus non-glomerular. Glomerular means from the glomerulus right up to the tubules, and non-glomerular means tubule onwards. After having introduced to you, now Priya is going to talk of one of the commonest cause of hematuria in children. On to Priya.
Thank you, ma'am. So I'm going to skip through the introduction and begin straight with the cases. So this is case 1. This is a 9-year-old girl who presents with a history of cola-colored urine and swelling of her face and legs for 2 days. She has no history of sore throat, and so the question that first arises would be, what kind of hematuria is this? Is this glomerular hematuria or lower urinary tract or non-glomerular hematuria? And the answer is evident from the cola-colored urine, so it would be glomerular hematuria. So the causes of glomerular hematuria broadly go into glomerulonephritis, or an inflammatory condition. Most commonly is acute post-infectious GN. In school-aged children, there's also IgA nephropathy, lupus, and the more rare kinds of glomerulonephritis, such as membranoproliferative glomerulonephritis. One vasculitis we see commonly in school-aged children is HSP, or Henoch-Schönlein purpura, where the child comes with a rash on their legs. The other cause of glomerular hematuria are the hereditary diseases of the basement membrane of the glomerulus, such as Alport's disease or thin basement membrane disease. Okay, so this is a question. So we have this girl with a 2-day history of cola-colored urine. She has no history of a sore throat. She has swelling. Which of the following additional points in the history is relevant? Question 1 is a history of skin boils on the legs 4 weeks ago. Number 2 is history of headache since this morning. Number 3 is history of less frequent urination than usual. And number 4 is all of the above. I think it gives you 10 seconds to answer the question on your clickers. Okay, so everyone got that correct. It is indeed all of the above. The reason for that is that not just throat infections but also impetigo can cause glomerulonephritis. Headaches is a symptom of hypertension, which is associated with glomerulonephritis. Obviously, oliguria is important as well. So in the clinic, her BP was 142/98 and she had generalized edema. A urinalysis with microscopy showed greater than 100 RBCs, a few WBCs, 2+ protein, and RBC casts were seen. So, the features of acute glomerulonephritis, as a quick reminder, include 3. Hematuria, it may be gross or it may be microscopic. Edema, which is the commonest presenting complaint of the family, and hypertension. Parents may also complain of oliguria. You may also find moderate, not severe proteinuria, and an elevated serum creatinine. The edema in nephrotic syndrome is different from glomerulonephritis because in nephrotic syndrome there is more of an accumulation in third spaces. So you'll find a pitting type of edema, you may find a lot of ascites or pleural effusions, whereas in glomerulonephritis it's more of a generalized type of edema. So 10 hours later, the child's in the emergency room and she is complaining of breathlessness. On examination, there are bilateral crepitations and there is a gallop. Her BP is now 160/104 millimeters of mercury. So the point here is to beware of severe hypertension and acute glomerulonephritis. And the reason that it causes symptoms so rapidly is because the rise of BP is very quick, as opposed to chronic kidney disease where it may take a period of months to years for the BP to slowly rise. Children don't tolerate rapid rises of BP well. So The target organ damage that occurs or the organ damage from hypertension includes congestive heart cardiac failure, which this girl presented with, as well as hypertensive encephalopathy, which presents as seizures. So a question, in this child with acute glomerulonephritis, hypertension and heart failure, which drug would you use first to treat the child? Amlodipine, IV labetalol, infusion sodium nitroprusside or IV furosemide Lasix? Okay, so the majority have indeed answered a diuretic. However, there have been a variety of other answers as well. And so glomerulonephritis is a state of salt and water retention. It causes intravascular volume overload and therefore causes heart failure, as well as the increased volume causes hypertension as well. So giving a diuretic is one way of treating severe hypertension that's different than in other conditions. Yes, amlodipine may be useful a little bit later. IV labetalol, if a child has heart failure, would be contraindicated. And sodium nitroprusside, I wouldn't use this first line. I think the best drug for a child with acute glomerulonephritis is a diuretic that's given IV. So we've discussed that. So the question, the child improves with giving 2 doses of Lasix, the BP improves, you continue your evaluation, and which of the following lab findings during your evaluation could be life-threatening in acute glomerulonephritis? Severe hyponatremia, uremia, hyperkalemia, or hypocalcemia? Great. So, indeed it is hyperkalemia. Hyponatremia is not a feature of acute glomerulonephritis. Renal dysfunction in acute post-strep GN is usually mild, so children don't get uremia. The reason for hyperkalemia is because there's a reduction in GFR. Because of the inflammation in the capillary walls, GFR is reduced and so potassium is not excreted. So this is the commonest and most severe abnormality to be aware of that needs sometimes emergent treatment. And hypocalcemia you see most often with chronic kidney disease. These, as you all can tell, are tall tented T waves. So a child with a potassium greater than 6 does need an ECG, and if tall tented T waves are present, then would need the whole treatment for hyperkalemia beginning with IV calcium gluconate. So the management of acute glomerulonephritis involves mainly restriction. It restricts fluids to insensibles plus urine output only, because remember this is a state of fluid overload. Reduce the salt, because the more salt the child eats, the more water the child retains. Restrict potassium. Diuretics are the mainstay of management, though some children may need a longer acting antihypertensive such as amlodipine. And antibiotics are worth giving because the strain that caused the glomerulonephritis, or a nephrogenic strain, may pass on to other members in the family as well. So in the evaluation of acute glomerulonephritis, the child has mild renal dysfunction, mild hyperkalemia, borderline ASLO titers, and a low C3. So diagnosis in this case would be a hypocomplementemic glomerulonephritis. It's likely to be acute post-streptococcal GN, even though the ASO titer is not elevated, because in skin or impetigo, skin infections or impetigo, it's the anti-DNase B that is elevated. Often we cannot easily measure it. So complement levels are very useful in the evaluation of acute glomerulonephritis, because a low C3 differentiates post-strep GN, which is the commonest form of acute glomerulonephritis, versus an IgA nephropathy or an HSP nephropathy that doesn't have a rash. But remember that a low C3 GN is also present in lupus as well as in MPGN. The differentiating factor will go on to a question later to see. So how do you confirm, this is a child who has a low C3, how do you confirm the diagnosis of a post-streptococcal glomerulonephritis? Number one is by performing a renal biopsy. And the question really is not all the ways that you can confirm it, but probably which is the best and simplest way to do it. Number 2 is monitoring for normalization of C3. Number 3 is to measure ANA antibodies, looking for lupus. Number 4 is to culture the throat or skin, looking for proof of a streptococcal infection. So again, a little variation in answers here. The majority, about 50% of you have said the answer is indeed number 2, by monitoring for normalization of C3 in 6 weeks. So number 1, it is not necessary to perform a renal biopsy in case of post-strep GN to confirm the diagnosis, because it is an invasive test. In post-streptococcal glomerulonephritis, C3 invariably goes back to normal between 6 to 8 weeks. If the C3 normalizes, there is usually no need to look for more serious types of vasculitis unless there are systemic symptoms such as joint pains, arthritis, and other symptoms of lupus. And culturing the throat or skin for streptococcus may not always give you it may not give you a positive answer if it is post-streptococcal GN, and many children do have a throat sort of colonization with strep that may give you a false positive. So what are the indications for biopsy in post-streptococcal glomerulonephritis? So at diagnosis, if the child has severe proteinuria, nephrotic range, greater than 40 milligram per meter squared, 4 plus protein on a dipstick, then that's an indication that this is not simple post-streptococcal glomerulonephritis. If the child comes in with a severe renal insufficiency, or during the course of the disease develops worsening renal function, then this child may have gone on to develop a rapidly progressive glomerulonephritis and therefore needs a biopsy because therapy is indicated. Usual therapy for RPGN includes steroids, which we don't usually give to children with post-streptococcal glomerulonephritis. And later on, if the child's C3 level does not come back to normal, then they may have membranoproliferative glomerulonephritis or lupus. And that's another indication to do a biopsy. So, a brief history of a patient who has something that may be confused with post-streptococcal glomerulonephritis. This is a 13-year-old girl who comes with a history of recurrent cola-colored urine for 1 year. Her hematuria starts at the time of a cold and resolves within 5 days. She has no edema or joint pains and her C3 is normal. So the diagnosis in this case would be an IgA nephropathy, and to make a diagnosis of IgA nephropathy, it can only be done by biopsy because you need to find the staining on immunofluorescence for IgA. So serum measurements of IgA are not helpful in confirming the diagnosis of an IgA nephropathy. Classically presents with recurrent hematuria at the time of an infection, usually a URI. So now we'll move on to a second type of hematuria, which Dr. Kumud Mehta will discuss with you. I'll advance the slides.
So the second case we are presenting is an 8-year-old schoolboy who was referred for recurrent hematuria. Priya presented one with a single episode of hematuria, and it had gone on for last 2 years. This 8-year-old schoolboy was referred for recurrent hematuria for 2 years, and he used to pass pinkish red urine for 5 to 6 days intermittently, painless hematuria to mark, and not associated with a upper respiratory infection. There was no fever, edema, there was no history of deafness, joint pains, and rash. Deafness, why? Because many of these children may be suffering from hereditary nephritis and hereditary diseases like Alport's. So a simple, sort of a question of deafness would put you in a right track. But it's a rare disease and one should not really, because in our country deafness could be due to otitis media. So you have to do the audiometry to find out whether it's a sensorineural deafness. And there was a history of vitamin D and calcium given by the doctor's advice for last 2 years. Now this point to be taken because many a times hypervitaminosis D or a hypercalciuria can be a cause of a hematuria. The child was well grown, weight of 20.8 kg, height 82, little short, but the parents were short. BP normal, systemic examination did not reveal anything. And there was causes of a non-glomerular hematuria, because in this child there was nothing more to go by. So there was no history of any trauma, there was no urinary infection, everything was, sort of a negative. There was no exercise-induced hematuria, which occurs in the latter part of the evening in school-going children, especially after playing football, etc. But it's never gross. And of course, rarer conditions may give rise to like structural anomalies. Drugs, very important to remember. NSAIDs are known to be a cause of hematuria, and one should not make use of, nimesulide, ibuprofen, especially if it has occurred in once and if it gets repeated. So it is to be very much in the renal vein thrombosis, rare causes, and there is a lump and pain in abdomen. It's usually, sort of associated with nephrotic syndrome. Now, in this particular child, a detailed past family history was obtained. The question is, which of the following is the most pertinent in this particular child? Yeah, go ahead. Yeah. So, is a maternal aunt has a history of SLE and on steroid therapy, or child had a cold with sore throat of 3 weeks ago, father and paternal grandfather have a history of kidney stones, or the child was given a course of antibiotics to treat urine infection during the last episode of hematuria 4 months ago. So can you please tell us? So the most important thing is a family history of kidney stones in the father or the grandfather. Remember that. So I find that quite a few of you have given that. And the other important thing, so family history is very important in recurrent hematuria, because more often than not, either you have, as I mentioned earlier, hypercalciuria, maybe Alport's is another disease where the family history is very important. And there is an entity called as benign familial hematuria, which does not require any investigation. So to find out the proper systematic investigations, a simple history from the parents makes a lot of difference in finding out what should be your next. Yeah. So in this particular child, the urine shows 4+ RBCs. There were no dysmorphic RBCs, no CAS, few WBC, and trace of proteinuria. Now trace proteinuria, no CAS, and very few WBC with RBC 4+ is indicative of a non-glomerular hematuria. Of course, there are specific tests, like you can do phase contrast microscopy and find out the dysmorphic RBCs, but it is not available freely by all the labs, or right stain, but rarely it is required. It's very rare that out of 100 cases, maybe one case I must have asked when I'm a little in confused state. And for the non-glomerular hematuria, the most important, as we mentioned, it is from tubules. So urine culture should be, there was no growth. Calcium, phosphorus, alkaline phosphatase, electrolytes, BUN, creatinine, etc. was done. That's not after referral to us, but much before that, because the parents were very much worried. And ultrasonography forms a very important investigation in non-glomerular hematuria. This is the ultrasound report which was shown irregular calcification in the pyramids, which was suggestive of nephrocalcinosis. I would like to mention there is a difference between nephrocalcinosis and nephrolithiasis. Nephrocalcinosis is a calcium deposition in the kidney, while nephrolithiasis are calculus formation in the urinary tract. That means from the, sort of a pelvis of the kidney, or in the kidney, in the ureter, in the bladder and downwards, then it is called a calculus, because it is formed in the, sort of a urine because of a number of, conditions. One of them most important in 50% of the cases is a calcium, extra calcium deposition. You have oxalate stones, you have calcium stones, you may have rarely the other kind of stones like uric acid, so on and so forth. So the question is, what is the most important next investigation that one should do? CT scan to rule out calculi, urine calcium upon creatinine ratio to evaluate for hypercalciuria, urine culture to rule out UTI, or ammonium chloride loading test to assess for distal RTA, because distal RTA is an important cause of nephrocalcinosis. Urine calcium creatinine ratio. I'm glad that most of you know that that was the important test. It's a very simple test. The screening test consists of urinary calcium upon creatinine ratio in a spot sample, and according to the age, but in school going children it is 0.2, remember. And if you do the 24 hours collection to quantitate, then it should be less than 4 milligram per kilogram in 24 hours. So that clinches the diagnosis of a hypercalciuria. So we have already answered this. In this particular child, the anxious parents had already gone to 2 nephrologists and 2 urologists, and they had done the whole lot of tests which is at the bottom of it, including the ammonium chloride loading, etc., etc. Everything was normal. But what was positive was calcium creatinine ratio of 0.48, which I mentioned more than 0.2 is significant, and 24 hours calcium excretion of 248 milligram, equivalent to 12.4 milligram per kg per day, while the normal is less than 4. That means 3 times the normal was there in the urine, and this was a typical case of a hypercalciuria. Next. We tried to rule out because it was suggested distal RTA, which was already done by the blood gas studies and also the ammonium chloride loading tests. So the final diagnosis in this 8-year-old child with recurrent hematuria, the most important being the grandfather and the father having had kidney stones. The grandfather was operated by open surgery because it was many years back. The father had undergone lithotripsy. So both of them must have been hypercalciuric but had formed stone. Now it was our responsibility to prevent stone in this child. So this child does not suffer. So are there treatments for hypercalciuria? Yes. So all of the following may be indicated in the treatment of hereditary hypercalciuria except, please tell us which are those. Treatment wise, hydrochlorothiazide 1 to 2 milligram per kg to reduce the urinary calcium excretion. The second is increase water intake. It's called hydrotherapy. 4 to 5 liters of water every day we have to ask these children. Oral potassium citrate 2 milliequivalents per kg. Supplementation to increase the solubility of the calcium. There are inhibitors of stone formation and there are proponents. The calcium definitely causes increased chance of a calculi, while the citrate dissolves these calcium crystals. So that is the basic, principle of the citrate therapy. And the last is increase sodium intake in the diet to promote calcium excretion. Next, please. The last. So which one of, except, remember the catch is, which is not to be done? Which is the type of a treatment? So in fact, in all calculi, the sodium intake should be reduced. Increased sodium intake is more, sort of a cause calculi. The last one, I think now, no? So what is the treatment ultimately? We gave potassium citrate, we gave hydrochlorothiazide. 2 years after the treatment with this, the urinary calcium excretion reduced from 12 to 2. Mild microscopic hematuria persisted for 13 years. Remember, it was all due to nephrocalcinosis. Ultrasonography at 13 years showed no calcification. At 19 years of age, there were no RBCs in the urine, and BUN creatinine was normal. Weight was good, height was good. He was short initially, but he caught up during puberty, and now he has joined engineering college. So this is a very satisfying, outcome of a child whose father and the grandfather suffered from calculi, but the child was not allowed to get calculi. Thank you very much. Do you have time? No, yeah. So, should we ask the audience or stop it?
I think what we will do is we'll take the questions from the audience at the end.
Okay.
We can actually take one or two now, and then we can take one or two questions now. Any questions from the audience here? Okay, fine. I think we move on. Yeah.
Come.
Next speaker is Dr. Sujata Sani. She is a well-known pediatric rheumatologist, one of the rare bird species as far as rheumatology is concerned, and she's going to talk on rheumatological problems in children. Dr. Sujata, would you please come? Can I request the organizers to please honor Dr. Sujata?
Oh, thank you so much. Good afternoon, everybody. I'm just trying to open the slides here. So I'm going to discuss a couple of cases with you. So here's the first patient. This is a 14-year-old female child who was apparently well until 2 months ago when she presents to your clinic with the following complaints. She has a history of joint pains and swelling of the small joints of the hands and painful stiff knees for the last 2 months. She also has a moderate grade fever of 200 to 101 degree Fahrenheit for the last month or so. In addition, she had complaints of a significant fatigability to the extent that she's unable to carry out her activities of daily living, and she's been finding it difficult to go to school regularly for the last 2 weeks. So the first question for the audience is, what percentage of a patient's diagnosis can be made from the history in children with rheumatological problems? So is it 1, 2, A, B, C or D? Okay, so we have an audience that is quite evenly spread all across. And just to let you know that actually pediatric rheumatology is a very clinical specialty and the correct answer is D. So you can make a diagnosis from the history. About 85% of the information for the patient is given from the history. So this is not a 5-minute consult for any child. And let's proceed onwards for this patient. So when you see any child with a rheumatological complaint, for example, a joint problem, when a child has joint pains, you want to find out does the child have arthritis or not. And if the child does have arthritis, then is it a standalone feature or is it indeed part and parcel of a connective tissue disease? The prototype is SLE, a vasculitis, and a prototypic vasculitis in pediatrics is HSP. Is it in fact a condition called Ponset's disease, which is a reactive form of tuberculosis in children with tuberculosis? Is it in fact a malignancy or is it a mimic? So when a child comes to you with joint pains, this is the kind of question you want to understand in your mind. Is it arthritis or not? Now, when you talk about arthritis, just as general pediatricians are very passionate about the details of fever, in the same way when you're a rheumatologist, you want to find out about the joint problem. What is the onset, the progress and the current status of the joints. And you have to take a very detailed history with the systems review to find out, is there something more or is it just the joint problem? And when you have a child who has joint pains, you want to try and differentiate, is it an inflammatory joint pain or is it a mechanical joint pain? So when a child has an inflammatory joint pain, for example in juvenile arthritis, this child will have a history of early morning stiffness, usually more than 30 minutes. The child gets better with mobility. There will be a history of a joint swelling, and the problem can be very variable from day to day. On the other hand, if a child has a mechanical joint pain, for example, a child who's very hypermobile, this child does not have early morning stiffness, the difficulties are aggravated with excessive activity, and the swelling of any of the joints is very, very transient. So once you've taken a history, whether it's inflammatory or non-inflammatory, you then have to go ahead for a detailed clinical exam. Now that is the purview really of a musculoskeletal workshop, but you need to learn how to examine the joints and screen the various the regions of the body, and that's very, very important. And keep it in mind that a history of joint swelling is much more specific for arthritis than is just simply joint pain. And when you want to take out the detail of arthritis from the child, again you have to get back to the history. You want to know the age of onset, the sex of the child, what was the onset, was it abrupt or insidious, was it preceded by any illness, how many joints were inflamed, were they large or small, upper limb, lower limb, symmetric, asymmetric, whether the spine was involved or not. Then you want to find out how much was the loss of function for that patient. Was it appropriate to the degree of disease or was it inappropriate? And that's very important for two reasons. One is that if the child is unable to move a particular area of the body and you have very little to find but the child looks very unwell, we suspect a malignancy. On the other hand, if in case the child has a marked disproportion, that is lack of ability to do anything but the child looks very well, you actually think it's psychosomatic. So loss of function is extremely important. Very often it is the extra-articular features that will lead you to the correct diagnosis. So you just don't examine the joints, you have to look at the child from head to toe. Again, the severity and the site of pain and the presence or the absence of sleep disturbance is extremely important. Being a pediatrician, you want to find out what are the developmental milestones, the growth of the child, any systemic abnormality, because there are many storage disorders that can mimic arthritis, and an example is a mucopolysaccharidosis. In addition, you want to go into the history of the family, and then finally you have very little time to look at the laboratory. So labs don't give you a huge amount, it's got to be the history. In addition to finding out whether the joint pain is inflammatory or non-inflammatory, you want to look at constitutional features. Many children with rheumatological problems have skin problems. They can have issues on the scalp, especially alopecia, and they can have all the systems that can be involved. On the other hand, when you want to tease out whether the arthritis and the joint pain is a manifestation of a systemic vasculitis, then you look for certain specific features, and there are really three windows to the blood vessels, and that is the skin, the lungs and the kidney. So by and large, if a child has got a significant systemic vasculitis, one of these three areas would be involved, and the skin would show you palpable purpura, sometimes livido. You can of course get arthritis in children with systemic vasculitis. You look for mononeuritis multiplex and so on and so forth. So you need a very, very detailed history. So now that you know that 85% of the diagnosis comes from the history, you go ahead and ask the family some more questions, and you are now given to understand that the child has a history of inflammatory joint pain, that she does have some constitutional features because she was having fever, and on direct questioning you understand that this child has got a photosensitivity, and 3 years ago she was diagnosed to have ITP, which resolved after a short course of steroids. So, what is the inference from this information that you have just been given? What of the 4 diagnoses could this child now have? Okay, I'm happy that again we have a very confused response, so we have to have many more rheumatology sessions. So this is certainly not an infection because the child has got a history of photosensitivity. Now name me one infection which has photosensitivity. This child had so-called ITP, so clearly it cannot be JIA. I told you in systemic vasculitides, you have specific features that we have not given you any detail about. And mind it that thrombocytopenia does not occur in vasculitides. So by exclusion, you're left with one diagnosis, and that is connective tissue disease. So this patient has got systemic complaints of fever and fatigability. She has a previous history of thrombocytopenia. She currently has arthritis and photosensitivity. So clearly this is a multi-system disorder. I have shown you 3 systems which are involved: the skin, the joint and the marrow, and this patient must have a connective tissue disease. So the information from the history is 85%, and that gives you a lot of detail. Now let's add on some more to the 85% by examining the patient, and you find that yes, she is pyrexial. You are now able to find activation of the reticular endothelial system because you find that the child has got diffuse lymphadenopathy. You confirm on clinical exam that she has symmetric small joint involvement of the hands and also swollen knees. And because you're a good clinician, my dear friend Nishant is here, so I cannot use the word astute. So you're a good clinician, so you find that she has a vasculitic rash behind the ears, and the other systems review is essentially unremarkable. So your examination is not complete because you've not yet done a blood pressure, and when you take the child's blood pressure, you find that she's hypertensive. So clearly your patient now has a 4th system involved, that is the kidneys, and you're confident that clinically you have made a diagnosis of lupus. And when you investigate her further, you find she's anemic, she's got a mild cytopenia, that is her TLC is low, she's got 3+ urinary protein, some RBCs, and you look at her ANA which is positive and the C3 also, that is low. So ladies and gentlemen, when you want to diagnose your patient, it's history, history and more history. 85% diagnosis from the history, 10% from examining the patient, and fancy labs only in 5%. So you have 2 children here who are showing you a malar rash. So what percentage of kids with lupus will present with a malar rash? Anybody in the audience? Is it 5%, 10, 20, 50, 100? At onset, it's only 40 to 50% of children who will have a malar rash. So what's the corollary? Up to half the children with lupus will not have the diagnosis written on their forehead. So the next question for the audience is, the current classification criteria for lupus are the ones that are given forward by the American College of Rheumatology, the European League Against Rheumatism, the British ILAG Lupus Assessment Group, or the Systemic Lupus International Collaborating Clinics. In the year 2014, which criteria will you use? Okay, excellent. So nearly half the audience says it's slick, and that is the correct answer. So just a couple of years ago, we have the new criteria, which are called the Systemic Lupus International Collaborating Clinics criteria. You're aware that up until now, the American College of Rheumatology criteria were used, where you needed to have 4 out of 11 criteria to diagnose lupus. Today, you have the SLIC criteria, which are a total of 17 criteria, and the key features of this criteria are, number 1, it is divided into clinical and immunological features, and number 2, you must have at least one immunological abnormality to diagnose lupus both in children and in adults. The only exception is a small cohort of kids or adults who may have lupus nephritis as the sole clinical criteria with the presence of an ANA or anti-dsDNA. That is the only exclusion where you do not need 4 out of the 17 criteria. We will not go into the details, but suffice it to say that dermatology has been given a huge emphasis so that the features for skin have been divided into acute and chronic, and then you have definitions for all the other criteria. And again, when you look at the hematology, anemia, leukopenia and thrombocytopenia have been divided into 3. And when you come to the immunological criteria, there has been more detail. The 2 important things to take away are the addition of complements being depleted as a criteria, and secondly, the presence of a direct Coombs test. So keep in mind that these criteria have to be cumulative and not concurrent. Right? So they have to be cumulative and not concurrent. So when you look at our patient, she had a history of a photosensitive rash, she had arthritis, she has current anemia and leukopenia, she had previous thrombocytopenia which I have not even entered here, and then she has 2 immunological criteria because she's ANA positive and she has a low C3. So clearly this patient has got lupus. And then just the last question for this particular case for the audience is, what is the screening test for lupus? The ANA on immunofluorescence, the double-stranded DNA, depletion of the complements, or all of the above? I think that we are going to have another class on rheumatology as the next session, and for all of you the screening test is only the ANA. Only the ANA. With the current state of art of doing the ANA on immunofluorescence, you are likely to miss less than 1% of patients. You only do the dsDNA and C3, C4 up front if you fall in one of the 2 categories. Number 1 is if you have a very friendly laboratory in your backyard, and number 2 if you actually diagnose the patient to have a lupus nephritis and you want to see how aggressive the disease is. Otherwise, there is no role of doing all of the above if you want to screen a patient. It's a pretty expensive screen. You simply need to do an ANA on immunofluorescence. And just to tell you that this is not made up from my head, this is a very nice paper of 2004 which tells you how you should screen your patients when you suspect different connective tissue diseases. So on your left column you have the tentative diagnosis, and top of the line is lupus, and when you look at the boxes, they are the screening test. When you look at the triangles, they are the secondary tests, and when you look at the circles, they are the additional tests. So please take away from this session that the screening test for lupus is only an ANA. Right? That's an extremely important takeaway. And again, I'd like to emphasize an ANA on immunofluorescence on a Hep2 cell line, not an ANA on ELISA. So from this particular patient, we have understood that when you want to find out the diagnosis for the child, you're trying to understand from a detailed history, does the child have arthritis or not? Is it a standalone problem or is it a multi-system problem? Are there any red flag signs on my patient's history or exam? Having done this, you want to find out what is the pattern that your child fits into. You then make a provisional diagnosis, never mind if it's wrong. Then you ask for only few investigations. Because if you ask for many investigations, I promise you most of them will come back positive, and then you will be even more confused. And once you've made a diagnosis, then your treatment choices will have to be in pediatric rheumatology, age appropriate, disease appropriate, family appropriate, and your one overriding goal has to be achieving inactive disease as soon as possible. It doesn't matter what drugs you use, your aim is to get the child normal as soon as possible. Because in pediatric rheumatology, most of the diseases are multi-system, and there is a concept of disease activity and disease-related damage. And if the disease persists for more than 6 months, then the damage begins, and in most cases it is irreversible. So, Chairman, do we have time for second case? Short? Yeah? Okay. So short second case for you. So this is a 12-year-old girl who's been unwell for 1 month. She's got a moderate grade fever and she feels very tired. She has a migratory pain and difficulty in the knee, followed by pain in the wrist, elbow, and then the shoulder. On clinical exam, she's febrile. She's got a short systolic murmur. She has arthralgia, but no clinical arthritis. She has got a modest anemia. She has got a TLC of 14,200, a platelet count of 1.1 lakhs, and an ESR of 66. She's sent along for an echo, and the friendly cardiologist says she's got a trivial mitral regurgitation, and the very friendly pediatrician makes a clinical diagnosis of acute rheumatic fever. The major criteria he takes is carditis, the minor of polyarthralgia, fever, elevated ESR, and the laboratory is so supportive, the ASO titer is 400. So this patient is started on aspirin and Pedia. So first question for you, do you agree with the diagnosis or not?